So this topic, I'll just summarize because it is a very huge topic. So I'll go through fast. So a non-selective elaborate approach is not required for a case of uveitis. Usually we go on doing all investigations available to know the cause of inflammation, but it doesn't require that. And all these investigations are more supportive, they don't confirm any diagnosis. And before investigating, going for lab investigation, we need to know how far the investigation is sensitive and specific. And main thing is in workup, the history taking. Usually we miss this. Once we have come to ophthalmology, we forget about the history taking. So history taking is very important, and complete ocular examination and physical examination is required. So with respect to age, once if suppose a child comes, then we need to think in terms of infective, and immunological is JRA, infective is toxocariasis. And middle age, young adults, think of autoimmune conditions like HLA, B27, Behçet's and Fuchs. And old age, again infective comes into picture, VKH, herpes, tuberculosis, leprosy. So these are the patterns which the etiology distributes. In male, if you think it is more in terms of ankylosing spondylitis, Rettus, Behçet's and sympathetic ophthalmia, as they are more prone for injuries. Male are more prone for injuries. And females, again, it is immunological, rheumatoid arthritis, JRA. And systemic conditions. If suppose patient has any autoimmune conditions like collagen vascular diseases, Behçet's, Rettus and VKH, these are all autoimmune conditions which we need to rule out from infective conditions like tuberculosis, toxo, post viral infections. So post viral infection can be mostly immunological indirectly, but the triggering event is viral infection. And immunosuppressive individuals, more common is endogenous endophthalmitis. If symptoms, if suppose patient present with pain and photophobia and redness, it's more of anterior uveitis. If he comes of floaters and decreased vision, it is more of intermediate and posterior uveitis. Pain on ocular movement, think in terms of posterior scleritis. And sudden bilateral vision loss is more in terms of bilateral inflammatory condition like VKH or sympathetic ophthalmia. So extraocular examination, if the patient has poliosis, think in terms of VKH and sympathetic ophthalmia. Erythema nodosum in case of sarcoid, Behçet's and tuberculosis. And cartilage loss, if patient has any nasal bridge loss or change in the architecture of pinna, think in terms of polychondritis and leprosy or vaginous. And pitting of nail bed is more common in psoriasis and Rettus. And oral ulcerations in Rettus and Behçet's. So this is a systemic examination. There are many other conditions. So here is a small example. A 25-year-old Indian farmer male comes with acute non-granulomatous unilateral anterior uveitis with hypopyon and past history of fever and jaundice. He has also occasional pain in hip and he has urethritis. So this is a short history. So with this we need to go for what could be the possible diagnosis. So first of all, history, demography, like he is an Indian and his occupation is farmer, and it is unilateral and acute. So with this picture we need to come to a common differential diagnosis, that is called, what is naming is nothing but unilateral acute non-granulomatous anterior uveitis, that is called naming of condition. Once we go into in that condition what all entities are present, then we need to go for meshing, like what are the possible differential diagnosis. We come to finally come to the condition. And from then, after coming to differential diagnosis, we need to rule out by lab tests, like either we need to rule out or rule in through lab tests. And from there, if you suppose patient has any systemic condition, please don't hesitate to refer to a specialist, because either pulmonologist or rheumatologist, they help us a lot. But one thing is, don't refer to them by providing a diagnosis. Like I am thinking in terms of tuberculosis, kindly rule out. So they will tell there is no tuberculosis, please you can start steroids. This is straightforward. So please don't go give them a diagnosis. Most of the chest physicians, they tell there is no pulmonary tuberculosis, you can go ahead with oral steroids, but they don't rule out extrapulmonary. So that we need to have in our picture. And from then we need to go for general and specific treatment. So with this example, what we can think of is ankylosing spondylitis. Patient has back pain. Leptospirosis, patient is a farmer. Ritter syndrome, he has urethritis. And Behcet's, he has oral ulceration. So all these conditions cause non-granulomatous anti-uveitis. So we need to know what all conditions cause non-granulomatous, what all cause granulomatous. So I want, just I'll go through this. I think we don't have time with all these things. Shall, huh? Yeah, child. Yeah, he has a 15-year-old, 12-year-old child. He has come with scleral nodule, and superiorly he has sclerokeratitis, superotemporal area. The tip and taking history, he had a father with exposure to tuberculosis, open case, and his MAN2 is positive. He had a positive MAN2, but chest X-ray is negative. With the history that his farmer is a known open tuberculosis patient, we need to go in terms of tuberculosis in this case. And tuberculosis typically presents with this type of sclerokeratitis, deep stromal keratitis, supratemporal, triangular, wedge-shaped scleritis. This is characteristic of tuberculosis. And there is a nodule as well. Patient was treated with ATT and is recovered completely, no recurrence. This is a case of, I think you can diagnose this. Yeah, VKH, bilateral, and this is the AV phase of pooling of dye. And this 15-year-old boy, history of fever 1 week back only for 3 days. He had pigmented granulomatous anterior uveitis with posterior cervical lymph node. And this is the picture, ARN. So this is a case of viral, he had a viral fever initially, and then that led to the acute natal necrosis. This patient present with pain right eye for 1 week, and pain has increased on movements, eye movement. So other eye, there was an injury in childhood. So with this, usually what we do is we are towards sympathetic ophthalmia, but sympathetic ophthalmia is bilateral, and even the theisical eye will be painful in the case of sympathetic ophthalmia. So this history is very important, whether really patient had one unilateral pain or a bilateral, and does he have any extraocular symptoms like headache, tinnitus, and all these things. So this patient, he has posterior scleritis and his MAN2 was positive. If you would have thought in terms of sympathetic ophthalmia, we would have started him on oral steroids, which would have aggravated the condition. Yeah, this is actually it's a serous retinal detachment. There is serous retinal detachment in posterior scleritis. Yeah, diffuse posterior scleritis, there is chance of serous detachment. You have seen, James? Diffuse posterior scleritis with serous detachments. So this patient has a diffuse scleritis, anti-scleritis. He had a nail infection, a nail bed infection. We thought in terms of fungal. Started him on oral antifungal treatment, but he didn't respond. Then slowly developed granulomatous anterior uveitis. Then we thought, and then we had a doubt. Done fundus exam. There is a lot of subretinal infiltrates, and then slowly other eye got involved. This eye has become theisical, and so we have done choroidal biopsy. It turned out to be lymphoma. So I think the time is up. So I think we can stop here. Thank you.
Thank you, Dr. Venu, for this